tool. It used to be nice.
Are we live then? Right. Okay, well, this is David Wood. I'd like to just get things started here. Some people will be dialing in still, but I wanted to start with the introduction that this is a Office of Continuing Medical Education for ETSU event. Up there on the screen is the event code, event ID 51064, and then that phone number, people can call in to get credit. We will also show that at the end, but I want to invite everyone here to call in to get CME credit. With that said, we look forward to a session on pediatric hypertension, and I want to introduce our two speakers and our case presenter. First, I'm very honored to introduce Ahmad Watad. Actually, I think I might. Can I stop share and put us back on? Is that putting us back on the screen here? Yeah. I want to introduce Dr. Ahmad Watad, who's been a faculty member of ETSU. He went to Padova University in Padova, Italy, and came here in 1988.
Here?
Yeah.
We're here. And East Tennessee?
Yeah,
East Tennessee, 1990, July 1990.
I'm sorry, I got that wrong.
I was in Louisiana back then.
Okay, no problem. So started as a faculty in 1990, so he's been here 28 years. He's been a critical faculty member in providing care for kids with renal disease, and we really look forward to his presentation. Also presenting with him is Michelle Johnson, she has an MS in human nutrition from Winthrop University, and she just got her PhD in early childhood education. So Dr. Johnson, we're welcome. And she does nutrition education in our clinic currently, and we look forward to that. As our first presenter, I want to introduce Melody Miller, one of our residents, and she'll be presenting the first case. And before we jump into that, I wanted to ask folks on the call if they could, I see some of you are muted and some are not, but if we could go around and just introduce who you are and where you're from, so we could just see who all is here. So Mark Moran, would you mind just unmuting and say where you're from?
Sure, I'm Mark Moran. I'm a physician assistant in primary care at the Lincoln Memorial University in Harrogate, Tennessee.
That's great. LMU, the best coach there is Omar Watad. He's a coach basketball. So I might as well go there.
Okay.
We are #1 in the nation in Division II. You know that.
That's right.
All right. Go
Rail splitters.
Rail splitters.
Okay. Rail splitters. Really? Okay. How about first choice pediatrics? Would you like to just say hello and who's there? You have to unmute first. Okay. How about SOFA pediatrics? Would you like to? Hello? Okay. Hood MS. You're muted. Maybe this is why we didn't do the introduction. That's okay.
This is Melissa Hood.
Hey, Melissa.
I'm the educational coordinator here at ETSU
Okay, great.
in CME.
And then, thank you. Dr. Lucas?
Hi, I'm on sick leave, but I'm trying to stay current in medicine.
Very good.
I hope you will
Intensive
feel
care.
better soon.
Yes, we wish you well.
Sure will.
ETSU Pediatrics? Is that us? Okay, sorry, that's us. And ETSU Pediatric Clinic should be dialing in soon. Well, so with no further ado, why don't we turn it over to Dr. Miller and she can present our first case.
So our first case is a 16-year-old male, initials NL, who presents to our pediatric nephrology clinic for evaluation of high blood pressure. He comes in and he reports that he had a routine physical exam in just a few months prior and was found to have high blood pressure in the office of 162/90. Repeat blood pressure was 155/62. They deny any signs or symptoms of high blood pressure, such as chest pain,
That's it.
Okay.
Between Becky and Dr. Miller, I like to ask what they want to ask this patient as far as if he has any signs and symptoms, and what are those signs and symptoms you'll be looking for. Becky, you start first.
Symptoms of high blood pressure?
If this kid come to you and you want to start just with the patient first, what kind of signs and symptoms you are going to be asking about?
And let me just introduce Becky Rowland, a
Yeah, we'd love
fourth year medical student. She's a little bit outside the camera area, but she'll come on in here and participate in our panel. There we go.
Okay, I'm here. I would ask if they had headaches, vision changes, chest pain, palpitations, swelling of hands and feet. Those questions.
You want to add something else?
blurry vision, double vision, headache.
Dizziness. So all these questions are appropriate specifically for the blood pressure, for the hypertension. And you're going to expand a little bit and ask other questions about thinking in the back of your mind. There are certain things that can cause high blood pressure, mainly kidneys. So we're going to be asking about kidneys. What else you want to ask?
Edema,
You mentioned the swelling.
Swelling,
Any gross hematuria,
blood in the urine,
abdominal pain.
back pain,
back pain, rashes, joint pain, history of infections in the past. We'll talk about past medical history later on, but all these things relative to when the kid comes in. Right. Let's go with past medical history. What kind of questions you want to ask?
history of any kidney problems in the past, like urinary tract infections or abnormal prenatal ultrasounds, structure of kidneys.
Any urological surgeries in the past?
And I might interject that anyone on the call could
Please,
please
Mark,
throw out questions. if
you can
you'd
throw
like.
questions or you can throw answers, whatever you want to do.
Anyone else that's on the call can
Yeah.
throw out a question.
Except Dr. Lucas. All right. Any urological surgeries? Any orthopedic surgeries lately? All right. He's a 15-year-old, you said, when he presented the first time. 16. It doesn't make a lot of sense to start asking about the neonatal period, but it's not out of question. If they have BPD, if they have lung problem, if they are on inhalers and all that stuff.
Yeah, whatever medications that they're on.
It's coming. It's coming.
History of trauma,
Absolutely.
he plays football and he got a bad hit in the back.
Absolutely. All right.
And he did not have any of that.
What about the family history? What do you want to ask about the family?
Any history of kidney failure, polycystic kidney disease, hypertension or heart disease?
Absolutely. Any cardiovascular events at young age. Young age is 70 these days. No, I'm just kidding. Young age, because I'm getting there. Young age is anybody under 50 years of age. That's red flag. Whether stroke or heart attack. And it's appropriate to ask about kidney disease, dialysis, transplant, all the other stuff that you ask about. Okay. What about diet? Dietary, what is he taking? What he's not taking? Whether food or drinks? Becky or Dr. Miller? Where's Dr. Miller?
Does he eat fast food a lot? Does he eat high fat, high sodium diet? How much water does he drink every day? If he drinks water, how much liquids he drinks every day in total? Vegetable intake.
Types of drinks.
Does he drink anything that we don't like?
Mountain Dew.
What do you tell me, the 5-day energy thingy?
Yes.
Does he take the 5-day energy thing?
I've
Does he
already
get
figured.
caffeine, all right? Teenagers, unfortunately, we don't like them for them to smoke, but they smoke. Is he a smoker? All these. Now, for females, this happens to be male contraceptives. Right? Somebody that takes medications over the counter like antihistamine, the congestant. All these legitimate questions, and you got to think about it as primary care physician.
Also recreational drug use, amphetamines.
Yeah, and I probably told you in those 2 weeks, or told Dr. Miller, like, via culpa. I don't check for those. I probably should. I'm glad Dr. Dodd and Dr. Wood would check for those on those teenagers. But probably a primary care physician can look for those too.
It's something to keep in the back of your mind for every adolescent. Anabolic steroids would be another.
Absolutely, absolutely. All right. What would you like to look for? What do we got? We sit past like a history, we get the diet, and it's a physical, right?
Is he doing, do we find out if he is doing lots of fast foods? Or we don't know that yet.
We are going to know that when you look at the exam.
Okay.
What do you
The answer is yes to all.
What are you looking for as far as the physical exam in a teenager who comes with high blood pressure? It's the most common things that you would see.
Obesity.
Obesity. And this guy was obese or thin?
He was obese.
What's his weight?
Greater than 97th percentile. He was 110 kilos.
110 kilos, age 16. Been seeing him for 4 or 5 years now. By the way, he's very, very smart. He is at Georgia Tech, which is a very good school, and he's doing engineering, space engineering. So he must be smarter than me, that's for sure. But he doesn't listen. So he was 110 at age 16. Unfortunately, he is now 140 kilos. And I love to start seeing patients. Somebody's calling.
Thank you.
Just to remind people on the phone, please mute if you want to ask a question, you're welcome to do so at any time and unmute. But if you are asking a question, please mute. Thank you. Was there any question?
Any questions from the far audience?
So we're in the middle of our physical exam.
We're in the middle of the physical exam. So the first thing that the nurse is going to give you, the vital signs, all right? So the kid is definitely obese, BMI above 30. Then you're going to listen to few things and feel few things. What would you like to feel that's important? And what would you like to listen to that's important? What would you like to look at? I usually straightforward. I go from HENT all the way down. And there are a few things that you might want to do a good physical exam, but at the same time, there are specific things for hypertension. You look on the eyes.
Look in the eyes.
Yeah.
Listen to the heart.
Well, before the heart, there is something up here.
Thyroid.
Yeah, before even the thyroid, there's still something here. You have tonsils enlarged, okay?
Yeah.
You have adenoids problem. You have sleep apnea, okay? And then you listen to the carotid. Do we have issues there? You are right. You get to the thyroid. Move down.
In the heart, lungs. CDA tenderness.
Sure.
Possibly.
Yeah.
Abdominal exam.
And the fancy brewery, abdominal brewery.
Really?
You know what? It's easy when you know that the kid has renal stenosis to hear the brewery, not before. But you listen to it. You start both ways, the back and the abdomen. What else?
Check
My pulses. Right?
pulses and
Yeah.
check extremities for edema.
That's as thorough as it can get when you are looking specifically for blood pressure reasons for it in physical exam in a male.
What do you expect to hear on the cardiac exam? The hypertensive teenager.
If
He has a normal heart.
the kid is hypertensive and has been hypertensive for a long time, he could have a murmur.
Or a heave.
We could have a heave.
What are you trying to look for in the pulses?
I don't know. Dr. Miller knows that.
Dr. Miller, what are you supposed to look for in the pulse?
Ruling out coarctation of the aorta.
How do you do that?
You palpate and make sure that they're bilaterally.
They're not delayed in the lower extremities, which is very hard on a teenager. You have to widen those rates. Or they're just lower down, in like
They're weak.
diminished.
They're diminished. They're weak. And the thing is that took the students and the residents, don't realize that the kid doesn't have murmur, then we don't have a problem with coarctation. The coarctation doesn't have to be only in the heart. They can have coarctation in the abdomen. And I have one kid that has it, that had surgery in Michigan, right? And that has severe hypertension. But again, the hypertension, if you look for the coarctation and the other things that not essential, they're going to be severely hypertensive, not 140/60 or 150/70. It'll be higher blood pressure. And the higher the blood pressure and the younger the child, and hopefully we'll be able to present something in the second case, the more likely you have reason for it. Secondary hypertension. Next. That's it.
Can I ask one quick question? So on a young person who's 200 and what, how many, 110 kilos, you said?
Yeah.
What's the appropriate blood pressure cuff size? And how do you make sure that you haven't had
We have it in the clinic, and everybody should have in the clinic 50,000 cuffs. And it's just in my presentation, I have it here, the size of it, but the largest size that you can have in your office, it should be used. All right.
So we are seeing a lot of adolescents that are overweight.
So we have here, I'm sorry, Dr. Wood,
Please continue.
adult large, the width centimeter 16, and the length is 38. That's the largest cuff. Obviously, the others, we have it in the presentation, hopefully.
Okay, so the largest cuff possible.
The largest cuff possible,
Both sides.
and never let the nurse do the blood pressure in the what do you call that room? In the waiting room or in the room,
Yeah, triage.
the triage room. Do it in the room that you see patients. Make sure they are comfortable for at least 2 to 3 minutes relaxed, and make sure that send them to Hawaii. That's what I do for all my teenagers. Send them to Hawaii, relaxed, blah, 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 and
Visual.
give me blood pressure. And don't rely only on one. Get at least 3.
Yeah. Okay.
Well, the kid is obese. Since Michelle is with us, let's fix the obesity first, then we'll tell you what we got as far as labs. Is that okay, Michelle? All right.
Let me then, I'm going to share the screen here. You get fancy. I am going to, okay, it's not letting me get down to, I want to get out of this presentation mode and go way down to that. Go ahead, Michelle. Thank you. I'll do it. I got it. Lots of ways to skin a cat here. There we go. So we want to talk about diet for someone that's overweight teenager.
Sure. And so the first thing, certainly we talk about overall healthy habits. And in the last presentation I did, we talked a little bit about the 3 parts for healthy living. And so we talk about diet, we talk about exercise, and we talk about beverages and what we drink. And this is just one handout that I edited slightly to talk about cardiovascular health and in general. And so this is really specific to limiting certain foods, focusing on things like cholesterol and fats, making sure that fats are less than 30% of your diet, talking about just, I would get a general idea of what their typical diet is, their typical exercise, and really target some specific changes that we could make to try to get them back into a weight loss pattern that would get them closer to a healthy weight. So at this point, if we're just looking at obesity in general, we're going to talk about an appropriate calorie range, limiting fast foods, limiting fried foods, limiting sugar sweetened beverages, limiting caffeine, all of the things that we've talked about here, and then figuring out a real practical way for them to incorporate 60 minutes of moderate to vigorous activity each day with the physician's approval based on their heart health. So that's kind of where I would start. The other ones are more specific to low sodium, so I don't know. You can look if you want to scroll through. So this just gives you an idea, and I can provide these handouts.
We'll post them on the
Okay.
website.
Yeah. So there's two. The one specific about cardiovascular meal recommendations, and then there's a couple that are more specifically low sodium diet. One for young children, and one that's more general ideas. But we talk about increasing fruits and vegetables, increasing grains, increasing fiber, and making sure they're not drinking whole milk, making sure their beverage are appropriate. Skim to 1% milk is what we kind of shoot for. Less processed foods, low fat choices in meat, trying not to eat as many of the fatty meats, more of the lean pork, lean chicken, including meatless meals as well. So all of those things are things that we would probably focus on, and unsaturated oils, some of the more heart healthy oils. So we'd have to really focus on that individual and what their current situation is, and really come up with an individualized plan.
Okay. Thank you.
Thank you so much.
Let me
Well, but before I keep going, I want to plead with Dr. Wood to let Michelle see patients from other practices, especially the one that has insurance. I mean, I had a kid today that I needed her to see the dietitian, all right? And I just gave no salt, low potassium, low fat. What else low? There's something else.
Phosphorus.
No phosphorus, all right? And she said, I've been trying. I said, HMG must have some. And HMG, a wholesome medical group, must have dietitian. What are you going to do? All right.
There's very limited nutritional counseling.
I know.
The outpatient setting.
I know.
It's a big
So
problem.
feel
Now,
free to go out and advocate.
most likely this patient has what we call essential hypertension. But if they show up in my door, my resident want me to do certain things to make sure that we are not missing anything. Since by and large, anybody who had secondary hypertension, it has to be kidneys, and otherwise, I'm a kidney guy, so I stick with my kidneys. So Dr. Miller is going to say what lab we did and what x-rays we did.
So we did a BMP for electrolytes, BUN, and creatinine.
Before that, we did the urine analysis, and the urine was normal, because if the urine has some protein, you move up to do CMP, not BMP.
We did a renin level.
What was that?
That was normal.
Renal level is almost automatic in my practice. Why that's important? Because if it is high, and not just a little bit high, all right? There are levels up to 12, but if it's really, really high, then you have to think about renal disease that's causing it. Whether it's the polycystic that was missed, or the renal stenosis that was missed, or the history of recurrent kidney infection that was missed, and we have reflux nephropathy and small kidneys. If the renal level is normal, all of that is out, right? But the thing is, renal level does not come quickly, and I still end up doing an ultrasound. All right, so go ahead, I'm sorry.
We did thyroid testing with a TSH of 4. And then we also checked urine hormones to rule out pheochromocytoma.
And that's sometimes at the demand of the family. And if you have not high blood pressure all the time, you have high blood pressure comes and goes, okay? And even if you don't have the flushing and the pallor and all the other stuff that you think about with pheochromocytoma, you got to if I have a kid in my office, the blood pressure is normal, but the doctor says, oh my gosh, it was high in my office several times, then I have to think about pheochromocytoma, and I have to do the urine hormones. And the urine hormones means epinephrine, norepinephrine, metanephrine, normetanephrine, and dopamine, and creatinine, because if you just do the hormones, they won't have the normal values. But if you do hormone creatinine ratio, you will have the hormonal value. And some people wants to go even fancier, and I'm not. They do blood tests for the same hormones.
What would you, in terms of this workup, for this particular child, they were seen in a primary care office. Would you recommend this entire workup, or would you recommend only a few early
I would
steps?
do my urinalysis, no question about it. I would do a kidney function, no question about it. T4, TSH, 111. I'll stop there. No urine hormones.
So, yeah. Ultrasound?
Coming.
No, I mean, would you recommend? that they-
Absolutely. Absolutely.
We did 24-hour blood pressure monitoring at that point. And do you want me to tell the results?
Now, the 24-hour blood pressure monitoring, if you are not 100% convinced there's a blood pressure issue or not, and if you are convinced maybe this is white coat disease, and blood pressure in our office was on the middle of the high side. So, but we went and just got the 24-hour blood pressure monitoring to confirm that we have problem with hypertension. This particular patient, although he's smart, his parents are smart, mother is a teacher and father is an engineer, so we want to make sure that everything done by the book. And the 24-hour blood pressure monitoring, I don't do them as often, and I tell the patient, come to my office, I'm going to give you a room, I'm going to give you a blood pressure machine, and we're going to do for free the 24-hour blood pressure monitoring, not for free. That's nursing. He's looking at me, why are you doing anything for free? Nursing visit, okay? So go ahead with the 24-hour blood pressure monitoring.
That showed 27 out of 42 readings with a systolic greater than 130. 10 of those readings were greater than 140. And 3 of those readings were above 150. So
no ifs and buts, the kid has high blood pressure. In adults, when you do the 24-hour blood pressure monitoring, if you have 25% of the readings above certain number, and these days 120/80 or 130/80, whatever, the AHA in November updated it and says 120/80 is the normal, and anything above that is abnormal, and you have to think about the diet that you just talked about. But I have more than half of them above 130/80.
Then we got a renal ultrasound, which was normal.
So that's
Are the 24-hour blood pressure monitors available throughout our entire region, or how do you actually
before
obtain those?
they were available actually in our practice. Pediatric cardiology was doing it for me, and they were doing a good job. Now it's available at the hospital. Some people feel like it's a hassle. They have to go to the hospital, pick up the machine, bring back the machine, and they don't want to do it over the weekdays because they go to school, and so it's hard. But it's available. It's available. Treatment. Okay, so did we treat the patient? Yeah, of course. So what did we say?
We started the patient on.
No, not medicine, before medicine. Dr. Johnson would be mad at me. Dr. Johnson would be mad at
Back to Dr. Johnson. So we're
Dr. Johnson would be mad at me if I didn't do what I needed to do.
okay, we're right here.
So I have 2 handouts in here. One of the things that we really do, and it's not in these handouts, is the DASH diet. Sort of seems to be our standard approach. And the DASH diet is high in fruits and vegetables, lower fat. It's not specifically targeting sodium per se, but if you do a low sodium diet in addition to the DASH diet, it's been really very effective. And so for most of our patients,
And you can Google DASH diet and
absolutely,
download the manual
and fantastic information. It's really what we should all be eating. You know, it's high fiber, lots of fruits, lots of veggies, more whole grains, less meat, less high fat meat.
You're making me feel guilty.
I know, well, you know, that's my job. That's what I do, right? That's what we do for a living. And that in itself is effective, but adding the low sodium piece to it is additionally effective. So there's two handouts here, and this one is just in general more of a low sodium diet across the age. Things like avoiding fast foods, avoiding high salty foods, avoiding cured and processed and smoked meats. In our area, we have to be considerate of things like buttermilk because that is a sort of a traditional beverage here. Bacon, all of those processed porks that tend to be a little bit higher, deli meats, things like that. So instead, more fresh meats, obviously. This is specifically sodium, so some of the foods that they're suggesting that you consume, they're not really limiting the fat here, but so some of those things are just more clean meats, basically more clean foods, less breading, less seasonings. I'm sticking some more natural seasonings like garlic and onion powder and things. But in this age group, really we're asking them to, if you want to go to the next one, limit the pizza, the things that these kids are eating a lot of. So fried chicken, fried nuggets, a lot of the fast food really. So the top 10 foods contain sodium, the bread and the rolls, the meats, crackers, chips, popcorn, all of the things that these teenagers really like to eat. So we need to give them some real approaches that are really something they can use day to day. Working with being knowledgeable about what foods are available at the schools, encouraging them to pick some of the healthier selections, healthy snacking, all of those things. And so really, again, we always take a very individualized approach, looking at what their diet consists of, and then really making specific target goals for that individual.
What about school breakfasts and lunches?
What's funny you asked that question. I just met this morning with the director of the Johnson City School System, for the food service director for the Johnson City School System. And we're looking at the breakfast cart and what items are on it and trying to come up with a healthy bunch or like a healthy selection so that I can at least encourage them to eat the things that, you know, are a little bit healthier, and then the same for lunch as well. It's really the breakfast cart that I'm targeting right now because a fair number of our patients are dependent on school food for their nutrition throughout the day. And so we're working together, and she was very excited about the idea of partnering and working on some ideas to include some physical activity, maybe to include some token type system, maybe some like punch cards to try to get the kids really interested. But that really is a community effort and just involves all the stakeholders. And so we're really trying to work on that. So we met this morning. I'm feeling pretty positive about that.
Thank you. For the patient, we wanted the patient to be on low salt diet, no caffeine, lose weight by diet and exercise, not just the patient, but sometimes the whole family needs to be together, okay? For the specific patients, I already told you as far as weight reduction, it didn't work. He moved from 110 to 130 over the 4 years. Kilos, yeah, kilos. And
do you have a weight reduction target?
I do. I do, because I look at the weight and height and percentile, and I don't want to discourage them. When they are 16, they are still growing. I says, if you just give me the next 3 months without getting any bigger, you will get taller. Give me another 3 months. It is giving the goals that are achievable. But if you say you're 110 and you have to be 80, that's 66 pounds. He's not going to come back, right? Yes.
But like to reduce, if somebody has essential hypertension, they're obese, if they lose, say, 10% of their body weight, would that resolve?
That would help. That would help. But I was telling Dr. Miller, more probably, Becky wasn't with me, that over the last 28 years that have been here, probably half a dozen patients that I was able to take them off medicine, all right? And those patients were on only one drug, And they were very, very motivated teenagers, and they lost the weight. And the weight loss should be about ideal weight. If you get to the ideal weight, you're going to be able to be without medications. So those are the things that we did, and we put them on blood pressure medicine. And we'll talk about all the blood pressure medications that we put on, but this specific patient, we put them on what?
Lisinopril.
Yeah, we put them on ACE inhibitor. Are there any questions from the audience before I can give the presentation, if Dr. Wood want me to do that? And if we have time, we can present a backward case, which is really helpful for the primary care physicians, whatever you guys want. Any questions from there?
So, well, one question about medication is, in a male adolescent, what do you start with? You start with lisinopril, ACE inhibitor?
Sure. I always make life easy on everybody, including the chairman and the workers with me. I say A, B, C, D. If you remember those four things, you will know what you want to choose, and I'll tell you what I choose. A for ACE inhibitor and ARB, B for beta blockers, C for calcium channel blockers, and D for diuretics.
I've never heard that before. That's good.
No, you heard it in Southwest Virginia, but you were.
I was asleep.
That's right. That's right. Now, let me tell you about the D. The D is more for adults than kids, because kids do not like to be stuck. They do not like to have the potassium supplement, and I don't have any problem not to give any diuretics. If you have to choose diuretics, you choose hydrochlorothiazide, you don't choose Lasix. Okay. I choose always ACE inhibitors in male. In females, never ACE inhibitors. I go with something else. My ACE inhibitors, there are 6, 7, 8 of them, and the adult guys know those numbers more than I do, but I stuck with 3. I use more lisinopril or enalapril, and in the old days, I used to use captopril. And you'd be surprised to know that none of them is approved by the FDA for kids, right? So, but we use them. And as far as the ARB, it will be a supplement if I have a problem with ACE inhibitors, the side effects from it, specifically chronic cough, mainly, and some people have some toxicity for it. Then for female who has the same issue, I'll go with calcium channel blocker. I'll just go with Norvasc or amlodipine. For emergencies, I use nifedipine if need be. Something. Beta blockers, I always use a target one that doesn't affect the sugars, doesn't affect the asthma, and I use that in a lot. So yes, ACE inhibitor is my first choice. And when you use ACE inhibitor, you bring them back 4 weeks or so, just to make sure that your creatinine is normal and your potassium is normal. So because it can cause hyperkalemia and it can cause decrease in kidney function.
Very good.
What do you want to do? Presentation or? I guess.
We can do another case.
Okay, the
Is that
backward
okay
case.
with people?
Is that okay with you?
There you go. I saw it. About.
Quick case.
Way to go.
Quick case. All right.
So we have a patient, CG. She's an 8-year-old female. Sorry, she's 18.
She was 18.
18-year-old female who presents to our pediatric nephrology clinic for hypertension secondary to left renal scarring and cysts on both of her kidneys.
This is basically the note from who knows. She's now a 24-year-old. I saw her from age 6. So I'm going to present the case because nothing is in there. From age 6 to age 23. Okay.
She presented to you at age 6.
She presented to me at age 6. Actually, the reason I'm bringing her as a case, because she presented to the PCP. The PCP, the first one, was a junior faculty from excellent practice, right? And the blood pressure, she presented with headache. It happens, her grandmother was working for us at one point as a nurse. And the headache, the blood pressure was 150, 160 over 90. And this is a 6-year-old, not 16, okay? Well, the junior said, because it's the headache and I don't believe the blood pressure number and pain, I'll bring you back in a week. Well, the senior pediatrician saw it in a week and called immediately because the blood pressure was even higher. I said, where's the kid? He said, in the office. I said, back then we didn't have intensive care unit doctors, or we did, but everybody admitted under his own service. So we admitted her to the PICU, we titrated her medications, put her on drips to control the medicine, and she was on 3 blood pressure medications at the beginning. The history was she never had kidney infections, all right? But if you don't check for it at age 1 and 2 and 6 months, you're not going to find it, the urinary tract infection. So,
I mean, if she had fevers, but no one checked for the urine.
well, nobody checked the urine, always the ears, always the throat, always, yeah.
It's a good take-home message.
Yeah, that's the most important point of this presentation. So we said, like always we do, we got our fancy renal level, sky high, we got our fancy ultrasound. She has a tiny shrunk kidney, and we got VCUG. She had huge reflux nephropathy. So the message is, the higher the blood pressure, the younger the child, the more likely you have a problem, the more likely you have a secondary cause of hypertension, and don't wait a week or 2 weeks, 3 weeks. At the end of the day, nothing bad happened except anxiety for the family, and the kid did well. Thank you. Any questions about this case before we move on and talk? All right. Looks like everybody's happy. This is a good presentation.
We're going to go to the presentations.
Oh, I don't have anything to disclose, but I didn't put that there. The family practitioner, the nurse, the physician assistant probably know that. There are about 17 million American adults have masked high blood pressure disease, and can lead to heart disease, and children more likely have more high blood pressure than we like to admit. Next. The blood pressure, there are normals. And if you look at the American Academy of Pediatrics, and I have it here, and it was in one of our presentations there, they have normal and abnormal on every patient for any age or any height. But generally speaking, normal blood pressure is less than 90 percentile. That's normal. Pre-hypertension, 90 to 95th percentile. Stage 1 hypertension between 95 to 99th percentile plus 5 millimeter Hg. And stage 2 hypertension above the 99th percentile. The same thing for teenagers, 12 to 17, except most people would use more than 120 over 80 is abnormal, and you have to take care of it. Next. The American Academy of Pediatrics does recommend that we need to check blood pressure on all patients 3 years and older, 3 to 18 years of age every year. And if you have problems with the blood pressure, then you have to do it more frequently or to act upon what you get. What about the children under 3 years of age? The ones that have certain medical conditions that can lead to high blood pressure. History of prematurity, resnal heart disease, recurrent kidney infections, hematuria, proteinuria, family history of congenital renal disease, children who have solid organ transplant, children who have taken medications that could raise the blood pressure. Teenagers might have the same symptoms that older adults can have. Headaches in 30% of the time, nausea and vomiting 13% of the time. When you come with hypertensive encephalopathy, you have to have a secondary reason for it, not essential hypertension. They can have secondary to polyuria, polydipsia, and uresis, all of it because there's a kidney issues. And they can have visual problems in about 5% of the cases. Working? Fatigue, irritability, heart failure in 5% of the cases, heart murmurs, facial palsy, and nosebleed. Nosebleed is common in kids. Picking the nose is more common than high blood pressure. But if somebody comes over and over with nosebleed, please check the blood pressure. There are transient hypertension that basically it will go away, but we need to treat it for a short period. Most of the time, kidney disease, as long as it's not chronic kidney disease, like acute glomerulonephritis, acute renal failure, HSP, urological surgery, orthopedic surgery, high calcium. Next. You can have with CNS diseases like tumor infection and injuries, Guillain-Barré, and drug therapy or overdose, whether steroid or contraceptive, drug abuse like cocaine, amphetamine, and PCP. By age group, in the newborn period, most common one is renal artery stenosis, renal vein thrombosis, renal artery thrombosis, and congenital renal malformation. Always you got to think about coarctation of the aorta, and they might not have any of the above, but they can have BPD. Between infants to 6 years of age, you start looking at renal parenchymal disease, renal artery stenosis, coarctation, and medications, such as albuterol, steroid, and pseudoephedrine. 6 to 10, like infants to 6. Adolescent, essential hypertension, we talked about the case. White coat hypertension, that's where you could be helped with 24-hour blood pressure monitoring. Still renal parenchymal disease, some endocrine causes, whether it's thyroid or pheochromocytoma. And thyroid is way more common than pheochromocytoma. Then adolescent physicians should check for substance abuse, tobacco, non-steroidal alcohol, and caffeine. Cyclic vomiting, yeah, next. Measurement of blood pressure in infants and children. Measuring blood pressure in infants and children is difficult. If you have an expected value, like the one that we just mentioned, 160 over 100 something and 6-year-old, don't wait for a week to see him. Do the blood pressure the next day or an hour later or 2 hours later, whatever you feel like you can do in your practice. Check the cuff side, and the circumstances of measurements should be correct, i.e. the coach should be calm for 3 minutes and should be comfortable. The room shouldn't be too cold or too hot. All these are important. And if somebody is annoying him, get it out of the room. Right? These are the sizes of the cuffs that you can use. Goes from the newborn period, 4 centimeter width with length of 8 to the adult, large adult, 16 and 38. Normal adult, 13 and 30. Next. Screening of hypertension in children. Patient history should include dietary salt intake, drinking alcohol, smoking, drug intake for both prescribed and illegal drugs. Specific questions regarding the presence of any headaches, visual disturbances, palpitation, nosebleed, rapid pulse, flushing, pale. Kidney issues, gross hematuria, edema, rashes, joint pain, extensive weight gain or loss, muscle cramps. Other symptoms of kidney disease should be included. Neonatal history of low birth weight. Obviously, this is for the 1-year-old, the 2-year-old, not the 20-year-old or the 18-year-old. Neonatal history of low birth weight and the use of umbilical artery and or having BPD later on. Next. Family history of hypertension is important, and early cardiovascular events are also important. Ask about kidney issues, endocrine issues, probably kidney the next. Exam, always weight, height, and BMI. The most common reason for high blood pressure in adolescent is being obese. Vital signs, you look tachycardia, you should consider hyperthyroidism, pheochromocytoma, neuroblastoma, primary hypertension, and don't forget the anxiety, because a lot of people have anxiety when they see doctors. Okay? And once they are not anxious or in a different environment, the blood pressure will be wrong. You check the decreased lower extremities for pulses, drop in blood pressure from upper to lower extremities. You have to think about coarctation. Look at the eyes, retinal changes, severe hypertension, most likely secondary. In the mouth, in the nose, adenotonsillar hypertrophy, sleep apnea, snoring, all that can be helpful. Moon faces, Cushing's syndrome, Elfman faces, Williams syndrome, female, webbed neck or spread nipples will come later, Turner syndrome, and thyromegaly, hyperthyroidism. Chest, it's here, Turner syndrome, we have widely spread nipples, heart murmurs, coarctation of the aorta, friction rub, SLE, interstitial disease, and collagen vascular disease. Masses in the abdomen, wounds, neuroblastoma, pheo, bruise, renal stenosis. Still, you want to make sure it's not polycystic kidney disease, multicystic kidney disease, or hydronephrosis. Skin, looking for flushing, or sweating, being pale, all these signs as pheochromocytoma. Acne, hirsutism, striae, steroid, Cushing's syndrome, anabolic steroid, and cafe au lait spots, neurofibromatosis. Skin continue, you have malar rash, lupus, acanthosis, and they taught me how to say it right, nigricans, right? Nigricans. Type 2 diabetes, wrinkled abdomen. They just saw one yesterday. Trombili syndrome, all right? These are the basic diagnostic tests that the general pediatrician should consider. You need to have urinalysis. If they are symptomatic, maybe urine culture. If they are not symptomatic, if it's a female, I'll probably get a urine culture. Then you get to have BMP and CBC2, like anemia for chronic disease. If there is a proteinuria, you get your CMP. I always like my renal level. Plasma inactivities, renal level, T4 TSH, and renal ultrasound. You look for congenital anomalies, discrepancies in the size of the kidneys, and the discrepancy is not 1 centimeter. 1 centimeter is probably within normal range. It has to be 1.5 and above, okay? And looking for scarring, cortical thinning, all this with good pediatric radiologists, they can tell you that. Additional studies, evaluation for comorbidity, fasting lipid profile, in obese kids, fasting glucose, and maybe you need to get an echocardiogram. Drug screen, I'm guilty that I don't do it as often as I should. Next. 24-hour blood pressure monitoring, specifically for a white coat. And if your office is not convinced that this is real hypertension, and if you're convinced that this is anxiety, nothing else, so just get white coat, just get 24-hour blood pressure monitoring to make sure that you are ruling all that out. The others are fancier studies. You want to rule out renal vascular images, renal scan, MRA, Dopplex, flow studies, all this. Again, this is to be really, really complete. Plasma and urine catecholamines. Next. How to manage these kids? The most important thing is what Dr. Johnson said. Try to lose weight. Try to lose weight by diet and exercise, and we'll go with your diets from now on. We give it to the people that we have, whether you see them or not. Weight reduction is the primary therapy for obesity-related hypertension. Prevalence of excess weight gain will limit future increase in blood pressure. Family must participate. Next. Regular exercise, 30 minutes if possible a day. Anything you can do to move, I'm fine with it. Walking, running, swimming, soccer, whatever you can do. Dietary modification, a fancy DASH diet, low salt, all right, and high calcium, no fat, no smoking, no caffeine, no alcohol. If you have persistent hypertension despite non-pharmacological measures, if you have symptomatic hypertension, like somebody comes with severe headache, dizziness, blurred vision, you don't have to wait. You just do the workup and start treating. And if you have hypertensive target organ, whether LVH or other problem, next. The focus here is to use drugs that preferably can be used once a day, maximize treatment dosage before adding another one. ABCD, you saw it? Right, I'm glad. ACE inhibitor, NARB, beta blocker, calcium channel blocker, and diuretics. And we're not going to talk about them. Be happy to send you another long version of this if anybody is interested. Just
So,
1 minute.
Thank you very much, Dr. Watad. That was
Thank you.
brief and good. Good summary. Thank you very much.
Thank you for moderating it. And
Well,
doing all
if there are
the
any,
comments.
we
Any
have just a
questions
couple
from there?
more minutes. If there's any questions from the audience, please either unmute and ask it or raise your hand. Had a good discussion, but there might be a question or two.
Becky, any questions? Because you always have some questions, challenging ones.
Becky didn't
Go, Becky.
realize she was going to be put on the
No,
spot
I
so much.
She doesn't.
She got made.
She's
Well,
speechless.
Thank you to both our resident and our student for helping us. Let me just remind people to call into that number to get CME credit, and please do fill out an evaluation. It's on the ECHO web page that you registered with, and we want to thank everybody. Thank you for Dr. Michelle Johnson and Dr. Rod Watad, and thank you so much for tuning in. And we will be sending out some notices about future ECHO meetings coming up. Thank you very much.
Thank you.
Thank you so much. Go Red Splitters.
That's right.
We have a game tomorrow and we have the best game on Saturday. Come and watch.
Free admission Saturday against Queens.
Yeah, we beat them by 1 point in Charlotte.
Right.
Okay, so
Splitters.
yeah, Rail Splitters.
Rail
Rail Splitters, yeah.
So
Hopefully we beat them better. We need to beat them twice.
Right.
Be able to host it at Turnigan.
Abraham.
Yes.
Okay, got it. Thank you. Bye-bye.
Thank you so much.
But